Good morning. My name is Peter Czarnecki. I'm the clinical director of ICU nephrology at the Brigham and Women's Hospital. I work both as a nephrologist and as an intensivist. So from that interdisciplinary perspective, I will give you a lecture on the acute kidney injury complex in COVID-19 disease. And this is my disclosure slide. I don't have anything to disclose that is relevant for this presentation. I decided that I will divide this in three parts for you, into an epidemiology part, then we will talk a little bit about pathobiology, and then we will talk about the clinical management. An important disclaimer right at the beginning: this is a very rapidly evolving field and everything is in flux. So all the data that I'm presenting today, you will have to take them a little bit with a grain of salt. This is the best available evidence, but we will have to see if it stands the test of time and if the scientific and medical community will be able to separate the wheat from the chaff in the next months. We're starting with the epidemiology. There are three major clinical manifestations that you need to be aware about when it is about acute kidney injury in COVID-19. Number one, acute kidney injury itself, defined as a rise in creatinine or as the development of oliguria, is not particularly common, even though the kidney is frequently affected by the COVID-19 virus, but it is probably the most important manifestation, AKI. Number two, AKI often coincides with hematuria and with proteinuria, as you can see here on the right panel, but this is neither specific, and we see different numbers across the board. It is a common manifestation, but it's not our main focus. Our main focus is truly the AKI manifestation, its severity spectrum, and the consequences that AKI has for the management of the patient with COVID-19. What do you need to know about the epidemiology of AKI itself? The best evidence comes from a paper by Hirsch from the relatively recent experience in New York. And I think there are three major points that you need to carry away from this. Number one, the cohort, probably 5,500 people, that is stratified here in no need for mechanical ventilation and yes need for mechanical ventilation, so basically critical illness or a surrogate for ICU admission, and AKI in various stages. This stratification indicates that AKI is actually not that common in this entire population of 5,500 people. Almost 3,500 did not have any kidney manifestation. Okay, so number one, remember AKI is seen, but it is not the focus number one. Number two, high degree acute kidney injury is very uncommon if people are not critically ill to begin with. So this entire left column here that summarizes AKI in all the people who are not critically ill and never had to be intubated shows that more severe AKI is less frequently observed, and like 0.2% of these people who did not make it to the ICU needed to start renal replacement therapy, while in those patients, number three, who are critically ill, AKI is an important factor that A, indicates and B, complicates acute critical illness. This slide is good in summarizing independent risk factors that the authors have elicited: older age, African American heritage, hypertension, diabetes, cardiovascular disease, but in particular vasopressor use indicating vasoplegia and shock in the ICU, and the need for mechanical ventilation, raising the odds of AKI by a factor 10.7. And what you can see here, in the course of COVID-19 disease, people develop symptoms, people become progressively more ill, and ultimately make it to the ICU and need to be intubated and started on mechanical ventilation, if they develop AKI, this AKI coincides with the timing of intubation. It is a very strong signal. Other data from the other epicenters of early COVID-19 disease in Wuhan made similar observations, proteinuria, hematuria, and AKI being major manifestations, and independent factors predicting bad outcomes. If you look at the cumulative incidence of in-hospital death, all three aspects, proteinuria, hematuria, and particularly AKI, are independently associated with a high risk of in-hospital mortality, even though the magnitude seems to be a little bit different in the New York study. But overall, I want to emphasize that the numbers paint a really dire picture. People in Wuhan who had AKI stage 3 had a mortality of in the high 90% range. The same number is a little bit lower in the New York experience, mortality of 54% in the AKI stage 3, but this lower number, I believe, is still not a reason for too much optimism here. We want to move on to the next chapter, that is the pathobiology of COVID-19 disease. And here, even more, it is very difficult to make clear and lasting statements about mechanisms of disease. Where does our pathobiology knowledge even come from? Well, we have autopsy cases. We have very few live kidney biopsy cases, and I think the most comprehensive study that was published is this one in Kidney International by Su et al. They looked at 26 autopsy cases, and they looked particularly at kidney histopathology. And you need to remember that there are 4 major patterns that the authors have looked into. Particularly into glomerular, tubular, vascular, and interstitial compartments on their assessment, and what they found was very little interstitial nephritis, the same type that we would see often in AKI secondary to drug associated allergic interstitial nephritis or in the autoimmune context. They found very little glomerular disease, only 2 out of 26 cases, and the major lesion was either tubular or vascular. The mechanisms are believed to be either through direct cytopathic effect of the virus invading tubular epithelial cells and leading to acute tubular injury or acute tubular necrosis, and on the other hand, vascular manifestations in the sense of endothelial activation, RBC congestion, and then secondarily leading to ischemia, particularly in the peritubular capillaries, and causing more profound tubular damage. So the tubular and the vascular pathology patterns, they are kind of linked because if tubular epithelial cells are not directly invaded by a virus, they may still suffer by the vascular manifestations and the ischemia. I also want to emphasize that the very low number in glomerular pathology that was seen in this study is probably not representative. It is useful because this is an early paper that already showed many aspects of the pathologic spectrum of COVID-19 in the kidney, but as you will see in a few slides, the genetic background in China is different than in the US, which has important implication for podocyte disease and glomerular pathology. This is a picture from a kidney autopsy case. Autopsy cases are always limited by the fact that there is a little bit of autolysis and postmortem changes, but pathologists can still tease out effects that happened in the lifetime of a patient, and we see necrotic tubules with this debris that is sloughed off. We see paucity of nuclei. We see pallor of cells. The cells are that are still here are swollen, kind of desquamating and being released into the tubular lumen, where they later appear as muddy brown casts. We see the loss of microvilli at the brush border. So these are very classic signs of direct tubular injury, and we would call this acute tubular injury, ATI, or being in the same spectrum with ATN. That's when we talk about frank necrosis. Here in other stains, you see an amplification of the vascular compartment. Peritubular capillaries are important because tubular ischemia often originates from here. And after staining of the peritubular basement membrane, you see that capillaries are filled with RBC. RBCs are congesting capillaries. There is absence of platelets, and we believe that this is an endothelial activation state with endothelial reaction, with endothelial swelling, and with downstream ischemia that tubular epithelial cells are suffering from. But we don't see a vasculitis pattern. We see sometimes very few cases of fibrin thrombi. Maybe thrombotic microangiopathy has a role in vascular beds that are more exposed to higher perfusion pressures, but the absence of true thrombi and platelet thrombi is something that was remarkable here. The genetic background in China is much different from the genetic background in America, particularly in the African American population. Many of you have heard about the ApoL1 locus, which is apolipoprotein that is subject to a wide range of genetic heterogeneity. There are two important coding variants in the ApoL1 locus that were discovered in 2010, actually here in Boston, and 13% of the African American population have one of these high-risk alleles that confers particular vulnerability to many causes of kidney disease. This is, on the one hand, a very interesting example of evolutionary biology and genetics, because when Europe got populated in the out of Africa movement, that was probably 20,000 to 100,000 years ago, and these genetic variants were not present in the European population, the prevalence of these high-risk alleles is very low, basically 0%. However, here in West Africa, we see up to 46% prevalence of these higher risk alleles from probably random mutations that occurred 4,000 years ago. They confer an evolutionary advantage, a protection against tryposomiasis, African sleeping sickness. And this is why this allele is so successful. And then obviously in the genome of many African Americans, these ApoL1 variants are present. And what our research has shown is that independent, that dependent on the ApoL1 high-risk variants, there is a much higher likelihood for certain kidney diseases. That includes lupus. That includes non-diabetic CKD. That includes graft survival in kidney transplant recipients. But what is particularly important also in the discussion of COVID-19 disease is that the odds for focal segmental glomerulosclerosis is extremely high, 17 times higher as in people with a normal ApoL1 variant. And in virus-mediated disease, HIV-associated nephropathy, both in the US or in Africa, there is an extremely strong correlation with those high-risk ApoL1 variants. In interferon therapy-associated FSGS, which is a certain side effect of interferon therapy, a cytokine storm is being attributed to the observed risk of FSGS. And from the few biopsies that have been done in COVID-19, where patients maybe even recover from the cardiopulmonary disease, but develop large proteinuria, FSGS, focal segmental glomerulosclerosis, is the most prevalent finding, particularly in Americans of African heritage. Much more research needs to be done to elicit the further mechanisms, but FSGS, particularly the so-called collapsing glomerulopathy, FSGS is the pathologic picture that many of our Chinese pathology colleagues have not observed in their autopsy series. I want to move on to the next chapter, and this is the clinical management of COVID-19 AKI, and this is mostly ICU medicine, because you have seen in the epidemiological discussion that AKI is a risk factor, or at least associated with and also complicating the disease. The more critical the disease is, the more does AKI play a role. And this is, to a certain extent, not about the kidney itself, because the question here is, can the kidney support critical organ functions with regard to solute clearance and with regard to volume management? The reason why these patients come to the ICU is because of ARDS. And what often coincides with ARDS is shock, is pressor requirement, and is vasoplegia. And in those situations, a failing kidney is more likely not to meet the volume management goals that are necessary to keep ventilated patients alive. And more rarely, we see that a reason for renal replacement therapy initiation is solute clearance, or that people rapidly develop uremia or hyperkalemia. We mostly see problems with the volume management. So when the answer to that first question, can the kidney support critical organ functions, is no, then the clinician is faced with the decision about renal replacement therapy initiation. Many reports were out there. There is literature about intermittent hemodialysis, CRT, and peritoneal dialysis as a renal replacement therapy modality in COVID disease. All of these therapies have their certain flavors, advantages, and disadvantages, and I want to discuss them both from a medical as well as from a resource management standpoint, because what the COVID-19 crisis brought to us was not only an exercise in medical and really disease pathophysiology-centered decision algorithms, it was also a very fine balance about what resources are available, how can I utilize the the environment in order to deliver the right therapy at the right time. So questions about how flexible is the use of any of these renal replacement therapy modalities. How do I manage the complications that are not COVID-19 or ARDS related, but that are related to the implementation of CRT or intermittent HD or peritoneal dialysis, for example? Do I have enough surge capacity to buffer a spike of COVID-19 ICU admissions with the hardware that I have and with the staff that I have? Yeah? Is staff attrition a major aspect in the delivery of care, or obviously dialysis nurses or critical care nurses can also be subject to COVID-19 disease at the same time as patients are getting sick. And then if I need personnel to perform one-to-one treatments, then these are all factors that play a role in the decisions of how renal replacement therapy is delivered in the time of crisis. Whether you talk about renal replacement therapy in the context of COVID or in AKI or ESRD in general, there are always these principles that play a role. The clearance of uremic toxins, the tight control of potassium homeostasis, the provision of adequate buffering capacity for the acid load that the kidney is incapable of excreting, to provide predictable clearance for pharmacologic therapy, particularly for antibiotic dosing, and very important in these cases here in COVID-19, the control of volume homeostasis. And this is a major difference that you will see between the patients with end-stage renal disease that everybody in internal medicine has seen. The end-stage renal disease patient needs dialysis on Monday, Wednesday, Friday in order to have to stay alive and to have mostly toxin clearance. Don't let the BON rise too high. And the volume homeostasis problem is something that is a variable between intradialytic weight gain, compliance with fluid restriction, and the patient's blood pressure, and it is managed with all scheduled treatments. In ARDS and in critical illness, volume homeostasis is probably one of the most important aspects. Everything else except acute onset of life-threatening hyperkalemia is secondary. And this is one of the aspects that plays a major role in our decision about renal replacement therapy modalities. The hemodialysis that you know is delivered by a hemodialysis nurse, as here in this picture from the New York Times. The dialysis nurse is a critical resource here. ICU treatments have to be supervised by a hemodialysis nurse one-to-one. This is different than in an outpatient or an inpatient hemodialysis unit where one nurse can take care of multiple patients at the same time. But with all PPE and ICU isolation requirements on top of everything, there is one patient and one nurse and one treatment, and that nurse cannot do anything else for 3 or 4 hours than treating care of this one patient. The major advantage of hemodialysis is that you attain superior solute clearance over a very short treatment period. And people who have a fistula, they can be hooked up to the fistula. Otherwise, a central venous catheter can be placed within minutes on an ICU. And the major limitation is that all the volume that needs to come out has to come out in a 3 to 4 hour treatment time. And outside of this treatment time, the patient is running positive. So those patients who can tolerate the swings in running positive with drips, infusions, medications, nutrition, and then being dialyzed every day or every other day and having this volume taken off, they are doing well with intermittent hemodialysis, whether this is in the ICU or not. Those who cannot tolerate any volume swings, either from hemodynamic purposes or from reasons associated with the profound hypoxemia that these patients are suffering from, they need continuous renal replacement therapy. I'm not going to go into the details of what different modalities exist within CRRT, but the aspects of CRRT are the following. We achieve excellent solute clearance in continuous therapy, but obviously this is less than a hemodialysis machine can provide. So I like to stress the major advantage of continuous renal replacement therapy is that it is continuous because it doesn't go away. It stays with the patient until the clinician decides to terminate the treatment. And with the so that phrasing that as an advantage is, it really is a superior treatment where we need precise volumetric adaptations, and those matter most in people who have profound hypoxemia or who are profoundly hemodynamically unstable. The advantage of CRRT is the patient can be made 200 milliliters negative last hour and can be kept even this hour and can be made 50 milliliters negative next hour, and this is how precise the volume adaptation can be. From the moment that you initiate CRRT, no patient needs to run even 1 milliliter positive, even except if the clinician decides that we want to run somebody positive. So for the management of ARDS, this is extremely helpful. What we have learned is resource utilization needs to be optimized in order to buffer a surge demand. We do everything to prevent a positive volume balance in those patients, particularly in those patients who are in severe ARDS, but also in those patients who are in less severe ARDS and who have just a very high mandatory fluid intake through therapeutic fluid. We have learned that these proning maneuvers that are helpful in mitigating VQ mismatches in profound ARDS give rise to positional flow-related issues, that these circuits break down, that we need to change filters, that there are treatment interruptions, and this is something that needs to be factored in. We have learned that patients who are oliguric and who need ECMO, for those people there is no alternative to CRRT for precise volume adaptation. And we have learned that abnormalities that are COVID-19 specific to the coagulation system impose a significant challenge in CRRT systems patency, because these systems clot off very easily, and we're going through many filters in patients with profound COVID-19 disease, and maintenance of adequate anticoagulation, often achieved with unfractionated heparin titrated to adequate goals, has been the key. Our experience has shown that the footprint of COVID ICU patients on the nephrology support structure is quite profound. Here you see at the Brigham and Women's Hospital how many people were COVID ICU admissions and how many of them were on the ventilator, and this is how many people required renal replacement therapy and who were actively managed by the ICU nephrology service. So here, like this, over time, this is the fractional representation here between 25 and 33%. So basically, between a quarter and a third of all ICU patients were followed by the ICU nephrology service or actively managed on renal replacement therapy for weeks and weeks and weeks during the peak of the crisis. And that shows you how large the footprint of the disease is on the kidney. So I want to move on to two board questions that I have put together in order to highlight some major points. Number one, SARS-CoV-2 infection causes multiple histologic patterns of kidney injury. Indicate the most common findings. Choose between A, immune complex mediated vasculitis, B, acute tubular injury or acute tubular necrosis, C, FSGS with tip lesion, D, and choose that B and C are correct statements, or E, all of the above. And you may think a little bit, cast your vote. And the correct answer here is B. Please remember, acute tubular injury is probably the most important and the most commonly found manifestation on histopathologic review, but the vessels are not exonerated from this. They play a major role. There is a lot of endothelial activation. There is a lot of RBC congestion, but this has nothing to do with vasculitis, and this has nothing to do with circulating immune complexes. Okay, so vessels, yes. Vasculitis, no. And then C is actually it's a close shot. FSGS is true. If I said FSGS, would be a correct answer. Yeah, FSGS with tip lesion is an isoform of FSGS that has nothing to do with COVID-19 disease. The pattern of FSGS that we see, particularly in African American patients with COVID-19 disease, is collapsing glomerulopathy. Okay, so here the tip lesion made C a wrong choice. Board question 2. A critically ill 39-year-old woman with COVID-19 suffers from AKI. She's in worsening ARDS. Intubated, mechanically ventilated, requires vasopressor support. Her BUN creatinine are worsening, but she has preserved urine output and diuretic response. These are ICU days, 4, 6, 8, and 10. Her creatinine is rising, 1.9, 2.7, 3.4, 4.2. The BUN is rising, 30s to 80s. The potassium is high, 5.1, fluctuating here and there. Also, does she have a base deficit? The bicarbonate is low. Now comes the therapy arm. We have to give therapeutic fluids, pressors, antibiotics. 3,400 in, and urine output 3,200. Here, day 6, these are the numbers. Day 8, these are the numbers. Day 10. So we can argue that the urine output is coming down, but she's still making 2 liters of urine per day on day 10. Norepinephrine in the low double-digit range for all the time. The furosemide support is titrated from 5 up to 20 milligrams per hour, and it stays at 20, which is the maximum dose in many centers. And here are the oxygenation parameters, initially at an FiO2 of 40% and with a PEEP of 10. The FiO2 is rising, the PEEP is rising. Here she's basically requiring maximum oxygenation support on the ventilator. When would it have been the most appropriate to initiate renal replacement therapy? And you have to choose between day 4, day 6, day 8, day 10, or actually not at all. Okay, this is a judgment call, and all these decisions are judgment calls, and we have decided, that the right answer is day number 6, based on the following parameters. the mandatory volume intake has always been in the 3.5 liter range, sometimes more, sometimes less. And the urine output was always preserved. However, you see that in order to generate the same urine output, the clinicians have to support her with maximum dose diuretic infusion. This has sharply increased from here to here. And even with maintenance of maximum diuretic infusion, the kidney function is obviously getting worse and the urine output is slowly coming down. This patient is running positive. Yeah, you can say that on day 4 she was mildly positive, but the gap is opening. On day 6 it is clear that she is half a kilogram positive, and this only gets worse. This may not be a problem in many people with critical illness who are easy to oxygenate, but this patient is more difficult to oxygenate, and basically her diuretic refractoriness and her AKI are coinciding with worsening oxygenation parameters. So I think we could have given her a chance on day 4 to declare herself and turn the corner. But I think on day 6, it is pretty clear that we're moving in the wrong direction. And at that point, it means don't hesitate, go in, establish an even or maybe even a negative fluid balance, titrating against your pressor support. And this has saved the life of many people with COVID-19 in our ICUs. And this is the end of my talk. I want to summarize COVID-19 real manifestations. Think about hematuria, think about proteinuria. They kind of muddy the picture, they're always there. AKI is the one that is associated with bad disease and with poor outcomes. We see tubular and vascular lesions predominantly, but particularly in America and maybe in Africa when we have some pathology data, glomerular lesions are important in the context of high-risk APOL1 genetic variants. And number 3, in the absence of any causative therapy, we need renal replacement therapy for cardiopulmonary support. The kidney is what it is, but patients die from shock and ARDS, and the implementation of renal replacement therapy, particularly for watertight volume management, is critically important to preserve critical organ functions in COVID-19 disease. I would like to thank my colleagues Samir Parikh and David Friedman from the Beth Israel Deaconess Medical Center and David Leaf here from Brigham and Women's Hospital for sharing slides and exchanging original content that I have used in this lecture. And a big salute to all hemodialysis nurses and critical care nurses who helped our patients and us to survive through this difficult time. Thank you for your attention.